hepatitis B, when I'm sure when you give talks and I give talks and Nancy gives talks, people's eyes just glaze over. They're like, "Oh, this is why I did not go into hepatology because this is way too complicated." So, what do you think about that in terms of, those are risk factors, and now we're telling people to understand their own risk factors.
Yeah.
Patients understand them less than physicians do. So, I
Yeah. Yeah, no, I agree. I think people have this trauma from med school where they see the squiggly lines, right? The viral load, the ALT, and then they're just like, "Oh, this is specialist matter." And we're trying to explain to people, "No, no, no, we need you to kind of step in. Otherwise, we're never going to get to viral hepatitis elimination if we only think of this as a specialist disease because it's so common." And a lot of people cannot make it to see hepatologists like you. So, and we are the ones that need on the front line who need to start the screening, and the vaccination and at least some of the initial testing. But yeah, so I think I agree. I think um, the hepatology guidelines are a lot for patients. I mean, for physicians to digest and get a lot of the nuances. The primary care guidance, which is hosted on the University of Washington website, is great because there is, and my favorite product out of the whole thing is like this one pager that we developed, and Nancy's seen it, and that is something you can print out, post somewhere, or keep a screenshot of it somewhere, but it's got like, what are the screening tests, right? Because we know often there is confusion on, do I need to do the e antigen for the screening? You do not. And even confusion like the core antibody test, right? A lot of times, and unfortunately, the test panels often include IgM when really you just need the IgG or the total for screening for chronic Hep B. And then it's got the table of interpretation, so you don't have to go Google it every single time, what the tests mean, and then a summary of the vaccines to recommend and the spacing and the vaccines that are out there, and then initial tests to order. And then it has like treatment indications, and it breaks it down just to like four indications. And one of them is the lab. It's looking at ALT abnormal and viral load over 2,000. And then fibrosis. So, looking at somebody with significant fibrosis. And we do have options for using elastography or APRI or FIB4. And then third is like comorbidities, somebody with HIV, although we would send them to infectious disease. But other things like family history, and we incorporate in that like somebody with high viral load, who's pregnant, by over 200,000 if they're pregnant, or a high risk of transmission, which is new in the AASLD guidelines, as you guys know. And then lastly, which I think is important, is an option that if a patient prefers treatment over monitoring, that alone would be a reason. And I think there's been so much discussion about this that, in this set of guidelines for AASLD, and I don't know that it's really obvious when you read it, but if you've heard any of the people, like Nora and even Mark, when they present about it, one of the things that we'd really wanted to shift from the previous set of guidelines is that nowhere does it say like there's a group that you cannot treat, right? So we're trying to make it so that potentially anybody with hepatitis B could be treated. And EASL is very clear about that in their guidelines. It says in theory, anybody who's surface antigen positive with viremia is a candidate for treatment. Obviously, the risks and benefits depend a lot about viral load and ALT specifically, but other risk factors. So I love that. I think that's a big shift that we should make sure is out there, that people are, and that's where the shared decision making comes in, right? So I agree that the word is probably thrown out there a lot out right now, and some of it is not in a good way, because I think we've heard a lot used in vaccination. And I think it makes sense if it's an equivalent choice that you have for a patient, like the risk benefits are equivalent. I think for vaccination, I think most of us would say Hep B vaccination, like it's a clear benefit over risk, but unfortunately it's been used as equivalent in shared decision making. And so I think for Hep B, like what AASLD did is use shared decision making for certain scenarios, for indeterminate, for the horizontal transmission, and e antigen positive, where it's not clear, then you can still offer it and discuss with patients. So, I think from the affected community, there was a really good survey done before the WHO guidelines, about 500 people with Hep B answered it. And it was really eye-opening because about half of the people who responded said their doctors never even mentioned to them that there was something they could take for hepatitis B. And so I think that's a failure on us, right? We've already made the decision for the patient. We already told the patient, you don't need it, or we didn't even say, we just didn't even offer it to them, right? So they're not even aware. So I think that's one thing we have to do on our side, is to at least inform patients that there are medications that can treat them. And then go into, why, my recommendation, whether I think you may or may not need it based on recommendations. And then the third step, when we talk about shared decision making, is then elicit or ask the patient to participate and ask them, what their preferences and values are. Like, do you want to be proactive and want to take medication? I mean, what we see a lot of patients do is when the doctor says there's nothing for you, they will go out and buy herbal medicines, right? Or something that we know does not work. So, logically, it doesn't make sense. Why am I letting the patient buy something and spend their money on something that is not effective, where they could easily take something that works well and, is affordable now because it's generic? So I think those are things we have to at least present to the patient, ask them what they want to do. And when they want to be proactive, then they have the option to take it. Or some patients, as you well know, don't want to be on medicine unless they absolutely have to, right? So it's helpful for us to ask the patient what they prefer. I think a lot of us physicians feel like we're already doing that, but I think we're not explicit enough about it. And this is where we can do a little better with that.